are probably familiar with the phrase, the two cultures, referring to the sciences and the arts and humanities. Many of us in academia intuitively understand what C.P. Snow meant, but the phrase continues to mean, at a time when funding and respect are decreasing for so-called soft disciplines like sociology, while funding and respect are increasing for hard disciplines like bioengineering. In preparing for this paper, I went back and read the essay by the British chemist and novelist that inspired his controversial 1959 lecture, The Two Cultures and the Scientific Revolution. Snow's thesis was this, and I quote, "The separation between the two cultures has been getting deeper under our eyes. There is now precious little communication between them, little but different kinds of incomprehension and dislike." End quote. Snow thought that traditional, mainly literary scholars were trained too narrowly to understand what he saw as an increasingly scientized and engineered world in the mid-20th century, while scientists had at least a modicum of knowledge about humanistic disciplines. That essay and lecture became a couple of books, and they spawned quite the debate about just how much communication takes place between artists and engineers. More conventionally, the phrase, the two cultures, is used as shorthand for everything that keeps humanists and scientists apart. Qualitative versus quantitative research, for instance. Long books that nobody reads versus dozens of short articles, each consisting of the smallest possible publishing unit and scattered across journals with suspiciously similar titles. Insistence on single authorship and a long acknowledgement section versus power struggles over the order of names on a paper with 6, or 12, or 50 authors. Some of this separation is the result of self-selection based on personal proclivities. The rest comes from conscious and unconscious socialization. I would like to reflect on these tensions in my own training, as both a historian and as a future physician, as if C.P. Snow had gone to graduate and medical school. As an idealistic pre-medical student, I once wrote an opinion piece in the college newspaper about the importance of the humanities to medical education. I still believe that, but let me tell you how I became more cynical about the two cultures divide. After taking an interdisciplinary course on memory during my very first grad semester, I was hired as a research assistant for a follow-up project. We were 2 professors and 2 graduate students, one each from history and neuroscience. My peer grad student and I worked wonderfully together because we recognized our own weaknesses and respected the other's disciplinary strengths. It got to the point at which we sat down at one computer to write together. However, things went much differently with the professors. The scientist preferred to direct the work of the junior team members and maintained a linear and monocausal worldview, while the historian was laissez-faire and encouraged plural and relativistic interpretations. Maybe that was just a quirk of different personalities, but I do not think so entirely. My experiences in graduate and medical school, and those of colleagues with whom I've discussed this, suggest that libraries and laboratories foster very different kinds of thinking and learning by design. As a graduate student, I sat around seminar tables discussing books with professors we called by their first names, and writing discursive papers about things like the shape of time. As a first-year medical student, or M1, I sat near the top of a tall auditorium while Professor so-and-so lectured from below. We spent our time cramming facts, preferably the ones that would be on the multiple-choice tests. A lot of the first-year curriculum seemed a lot like the pre-medical curriculum, hoops to jump through until you got to the good stuff later, namely clinical encounters with real patients. Not much has changed since I started medical school 6 years ago. This past year's open-minded M1s complained about the lack of time and encouragement to pursue their curiosity and to think creatively about medicine. So, a few of them created a reading and discussion group called Redefined Physicians. Even before earning my PhD, I was a practicing historian. Now that I'm back in clinical rotations, I'm at the bottom of the totem pole. What graduate school did was give me privilege and perspective. By the time I started medical school at the age of 26, I had attended half a dozen conferences to give papers, worked as an editor's assistant at the university press, traveled to Europe 3 times, and defended an original dissertation proposal. I had also matured in ways that I think had little to do with my graduate education and more to do with these independence building life experiences and the mere fact of growing older. Students in my M1 class who had come straight out of undergrad without taking time off for work, research, or travel tended to be more likely to stress out about exams than the older students, who seemed to have learned that their self-worth was not directly proportional to their grades. The older ones were also less likely to be what we call gunners, learning every anatomical structure on every cadaver, instead of relying on more flexible and deductive reasoning about shape and place. Medicine is both an art and a science. A chemical drug with a known action still has to be prescribed with the patient's willingness to take it, for instance. But the scientific side currently predominates. Western medical schools today require intimate familiarity with anatomy, physiology, genetics, histology, pathology, but not the ability to recognize social determinants of health, not the ability to calculate the moral hazard of universal health insurance, not the ability to perceive the power dynamics between a gynecologist, a deaf patient, and a male sign language interpreter. The fact that at last count only 1/3 of American and Canadian medical schools offer medical humanities courses, and that the Association of American Medical Colleges is redesigning the MCAT entrance exam requirements to include, among other things, more multiple choice questions about cultural competency, only goes to show that tomorrow's clinicians are trained first and foremost in the sciences. The arts are for the front cover of the Journal of the American Medical Association and the lobbies of hospitals, but not medical students' finite classroom hours. Like C.P. Snow half a century ago, I have experienced a disciplinary divide between the arts and the sciences. It sometimes feels like I am laying my body across a chasm. That chasm widened when the members of that M1 reading group collectively laughed when I began a comment about the residency match program with, "In the years after World War II." It widens when the medicine and society course at this medical school is taught by a physician with no humanistic training, as if medical humanities were a poem and a story about this one time they treated a patient who. It is a divide nurtured by structural and personal differences that all the rhetoric of inter, trans, or multidisciplinarity cannot entirely paper over. And it is not just the traditional literary scholars who are at fault anymore. I submit that medical students are consciously and unconsciously trained so narrowly that they understand neither the arts and humanities nor the medicine they are practicing with patients who are whole persons set in complex and institutional contexts. I chose to pursue dual MD PhD degrees so that I can make a career of the kind of translational research that can bridge the two-culture divide. On the one hand, physicians translate bench science into bedside care. On the other hand, historians bring their lived experiences to their studies of the past. Clinician historians like myself find that our medical training gives us uniquely clinical perspectives on the history of bodies and disease, while our historical ways of thinking give us useful insights on the practice of medicine today. I do not think that I will discover a long-forgotten cure in my historical researches. Rather, what I bring to medicine is a critical mindset that declares that just because this is the way something is done now, does not mean that it is the best or only way of doing it. I bring a humanistic approach to both the system of medical practice and to individual patient-clinician relationships. And I see my graduate education in European history, in feminist theory, and in disability studies as a way of personally bridging the gap between the art and the science of medicine. The other papers in this panel contribute critical views of medicine and medical education from the perspectives of women of color, queer and feminist theories, and ethnography. Thank you.